So after you got your FACS, and that happened a couple of years after your experience, correct?
Yep.
And then you've been practicing as a general surgeon, minimally invasive surgeon, bariatric surgeon. So let's talk a little bit about what it is to be a bariatric surgeon. So obviously, I think one of the biggest comorbidities that humanity has been going through is obesity. I saw in the WHO that in 2022, there was around 2.5 billion people that were overweight, which is an insane amount. And around approximately a billion of those are morbidly obese. So obviously it's, I would say like maybe a pandemic. Let's not say that word again.
It's an epidemic, yeah. It is a problem. It's a problem that's facing us all. And, it's not, we have, I think, evolved enough to realize that obesity is not something that we think of negatively about a person. It's a chronic condition. It's a disease that we live with. And even if an obese patient has lost their weight, they're still labeled as a patient with obesity or a history of obesity because their body or their body habitus or body type will continue to face that problem for the rest of their life. And so they constantly have to be adjusting their life and their lifestyle to avoid having a return to this problem. So it's a lifetime condition, it's a chronic condition. Yeah. And that's why bariatrics was born. And bariatrics was born, basically bariatrics involves weight loss surgery or metabolic surgery. And it has multiple ways in which it helps you with losing the weight. But what I really like to emphasize here is patients need to have a good awareness of what the surgery entails. Preparation for the surgery, in the US we used to have the patients go through a 6-month process before they're even eligible for surgery.
Wow.
6 months. Whereas in other parts of the world, they want their surgery tomorrow. And I mean, how can you...
And it's a multidisciplinary approach,
It is. I mean, you need these patients to be informed of what potential complications they might have, what things they need to do for life after surgery, such as taking their vitamins, keeping visits with their physician, and making sure that their visits with their dietitian are routine post-op, because it's so easy to just drift back after you feel like you've lost the weight. You slowly drift back into your old habits, and the weight, it might just be 1 or 2 kilos per year, but put 15, 20 years to that, and you're back to square one.
Right.
So there are different procedures that are out there.
So that brings me to the next points. Like, what are the different surgeries that a bariatric surgeon can perform to have that weight loss? I
mean, I feel like patients are going to be very overwhelmed by the number of surgeries and procedures that are out there. Yeah, there are quite a few. Many have gone out of fashion, and many have returned back in fashion. But if I were to kind of divide things or classify things, think of them in terms of restrictive, so decreasing the amount that you can eat, and malabsorptive, meaning decreasing the amount that you can absorb. So there's the most common procedure done is a sleeve gastrectomy, which is where they remove around 70% of your stomach. That leaves you with kind of like a banana of a stomach, okay? So that restricts the amount that you can eat. The cool thing about it is that it actually removes the part of the stomach that produces a hormone that gives you that sensation of hunger. So
what is that hormone?
It's called ghrelin. Okay, so it makes you feel like, okay, I don't really want to eat. Even though I'm not eating much, I still don't really want to eat, which is really good. And, it's been proven to give you over 50% excess body weight loss. So that is great, but you shouldn't do it for patients that have significant reflux. Because that reflux, you know the feeling of reflux? I mean, it's that acid that you get after you eat, and it feels horrible. But it gets worse after you get a sleeve. Right. So it's not for everyone, but very good weight loss mechanism. And then the other is the gold standard, you could say. It's been around for 70 years now, the gastric bypass. So you hear about the gastric bypass. You just make a little pouch of the stomach so you eat less. And they also reroute the intestine so that the food doesn't meet the digestive enzymes until later in the process. So
is that the Roux and Y?
That's the Roux and Y,
Okay,
correct.
got it.
And so the food comes down, does not get absorbed all the way until it meets with the enzymes later downstream. And that's when absorption starts and you're able to gain the nutrients. Problems with that are obviously nutritional deficiencies from vitamins.
So is that the absorption one that you're talking about? The other one was
this one is a combination of both.
Oh, okay.
The gastric bypass does restrictive because you're creating a small pouch, and malabsorptive because you're decreasing the amount that you can absorb.
And I guess obviously you become like vitamin deficient and...
Correct. So you have to take your vitamins for life. And very important, and we try to emphasize this a lot to our patient population, do not get pregnant in the first year to 2 years after these surgeries. Because, you know, you're going to have numerous visits to the emergency room with severe abdominal pain. And for bariatric patients, our advanced imaging is really important to identify problems because physical exam alone is not as sensitive to identify the pathology. And so, sadly, I've had a lot of pregnant patients that come in and the emergency room physician does not want to do further imaging,
like a CT,
and we miss something that's very severe, that's a bariatric complication. So on top of that, you got the nutritional deficiencies that can develop in the baby, in the fetus, and so you really want to avoid that in the first 2 years after bariatric surgery.
Right, that's very interesting. All right, tell me a little bit about the team approach when it comes to bariatrics. Bariatrics is unique. That's actually, I think of it as very similar to my specialty, where a lot of specialties have to be involved with each other. And I'm assuming similarly, you mentioned as a nutritionist, maybe a psychologist, maybe an endocrinologist. So tell me what the team is revolved around.
Absolutely. Yeah, I mean, the core team involves a surgeon, a dietitian, an endocrinologist, and a psychologist. Now, that is the core team that needs to approve each and every case. But additionally, you have cases where you have a patient with severe pulmonary problems, because a lot of obese patients have problems with sleep apnea. And so a lot of them need what we call a CPAP machine. It's like the extra pressure that can be used at night to help prevent dropping your oxygen levels while you're sleeping. So pulmonologists get involved, cardiologists get involved. And whenever we have difficult cases that we're not entirely sure when is the right time to intervene, we have these weekly meetings with the group to discuss the more complex and difficult cases and decide when is the most appropriate time to actually go in. Sometimes we might need to hold on the surgery until they prove to us that they lose weight on their own, at least 5 to 10 kilos before we work on them. Maybe it's a motivational issue. Sometimes we have the cardiologist do a catheterization and help open up their coronary arteries to avoid having a heart attack after surgery. Wait a few months and then operate on them. So that's why, you know, if it's a one-man show, your complication rates will be much higher, and it's endangering the patient. So that's why a multidisciplinary approach saves lives. Yeah, for sure.
No, definitely. So now we're talking about obesity and all that. Obviously, you know probably a lot more than me with Ozempic. Ozempic is extremely common now. It's driving me crazy in dentistry because the second I do anything in the patient's mouth, they just will start gagging like crazy, and then I have to like stop and be like, okay, let's give it a couple of days and then come back to me.
Sure.
So that's one side effect that I get annoyed by. So tell me a little bit about Ozempic and how that affected your practice.
Well, let's start with COVID, because someone who has freshly completed a bariatric fellowship, about to start his practice, gets hit with COVID. And that's 2 years completely with no elective surgeries. So that really hit the bariatric practices throughout the world really hard. You get out of COVID, and then you get all the GLP-1 medications, which further, I mean, most practices in the world have had a 40% to 50% drop in the number of procedures.
Wow.
So, listen, I'm not someone who would tell you I hate those medications. No, they have a huge role to play, and a great role to play. I prefer that the patient who has a lower BMI go through all kinds of different methods to lose the weight. I mean, that's advantageous to the patient. I want what's best for the patient.
Invasive.
Yeah. But you got to think about the BMI and the patient's comorbidities. So, one of the criteria for a patient to be eligible for bariatric surgery is that the BMI be over 40. So BMI is basically the weight over the height squared. So if it's over 40, then you should consider the patient for bariatric surgery. If it's over 35, between 35 and 40, you need to have a couple of comorbidities. What we mean by comorbidities are conditions that are related to obesity. So those could be high blood pressure on medications, diabetes on medications, high cholesterol, fatty liver disease. There's a whole list of pathologies that would be considered for those patients. So if you tell me a patient with a BMI of 45 or 50 is on those medications that you're talking about, Ozempic or others, I would tell you that's not going to work. I mean, think about it.
You're not solving the underlying issue.
You're not solving the issue. The medications only work if they're lifelong. You got to take them all along, because every study has shown that once you stop it, you're going to regain the weight.
Right.
And it's going to give you maybe a 30% at most weight loss. So if you're a BMI 50, then at best you're not going to get to beyond 35 to 40. You're still obese. So it hasn't really solved your metabolic issues. And I'm one of those proponents that I'm not doing this procedure to patients for their looks. I'm doing it to save them from their comorbidities.
Exactly.
I want them to be able to spend time with their families, with their kids, be able to move around, have a longer life, their heart, their kidneys, their breathing, their knees, their back. I mean, all that gets better once you lose the weight. So.
Right. It even showed that it decreases osteoarthritis, which I thought that was very random. Then I started thinking about it. I was like, yeah, it makes total sense.
Absolutely.
Yeah. Well, it works. It works. I think the thing that scares me the most about Ozempic is when it's not indicated for people, yet they take it. And I think this is where it gets a little scary, because there's always, throughout our entire life, there's always been a craze about, I gotta lose weight, I gotta look good, and then the lack of education, along with the ease of getting such medications, and now they're doing pill form, which makes it even easier to take it. I think this is where it gets a little scary.
Yeah, it is. And if I can add, there are at least 3 medications on the market now: Ozempic, Wegovy, and Mounjaro, and each has its own set of studies that show their efficacy. And they're really, Ozempic's been around for over 20 years.
Right.
Yeah, and so it's been used to treat diabetes. Exactly. And so we know that they are associated with certain side effects. Of course, surgery is associated with side effects and complications as well. So it's not like you're not going to get any side effects with any other method of weight loss. However, being under the supervision of a physician is extremely important to minimize the risk. And also, if I can make the public aware of medications that are being mixed and brought in from unknown sources, labeled as weight loss drugs, there's a concern for contamination, there's a concern for incorrect dosages, and worse, a higher risk for side effects. And that's becoming more of an issue for patients, because they want to get the cheaper version, etc. That increases the risk. But usually the risks are, the side effects are kind of universal in terms of the nausea and vomiting. It's worse in the first week or two after using the medication, and it slows down the stomach, the pumping of the stomach, so that makes you feel full all the time. So that's kind of how it works. And it promotes the secretion of insulin, which helps with managing the diabetes.
Yeah. I think the scariest thing, that at least for me, that I've been reading about is, when it comes to aging, I think one of the biggest factors is actual muscle mass. When it comes to aging, let's say, gracefully. And Ozempic really lowers the body mass, the muscle body mass, which is not good, at least for aging and for overall health. I think muscles play a huge role in overall health and well-being, and Ozempic destroys that. Let's talk a little bit about dentistry. Let's put medicine aside. So one thing with bariatrics, and you mentioned that, is it increases the reflux. And there's been an association and a correlation between dental erosion and bariatric surgery. You mentioned the team, but I didn't hear you talk anything about dentistry.
I'm just gonna say one thing, man. 2016, that's when we started talking about this topic. What is it now, 2024? We haven't published it yet.
That's true.
We've been talking about this this association because we're trying to work something out between the two of us in terms of research.
Right.
But yeah, I mean, we just mentioned a little bit about reflux and bariatric surgery. Now, when you, as we discussed, the sleeve is one of the very common procedures.
Right.
And what it is you create a high pressure system within the stomach. So anyone with reflux would be as a result of a weak sphincter between your diaphragm connecting your esophagus and your stomach. So if that is a little weaker, and then you give them a sleeve, that pressure is so high, your reflux is going to get worse. Right. And if you have acid pouring into your mouth all the time, and the thing is, a lot of it is you being unaware at night when you're asleep. It's been shown to increase dental erosion.
Yeah, there's a very recent systematic review that correlated the two and talked about how dentists needs to be included into your team. So I hope that you include me next time you have a surgery.
I would love to, man. As long as you guys don't give us your 2 cents and start like telling us what to do.
Be like, hey, wait, I gotta do a full mouth rehab before you do this.
Just remember, a team leader is always the surgeon, okay?
Got you. Okay, so that's bariatric surgery. To my knowledge, you're also an abdominal reconstructive surgeon, meaning that there's any hernias or anything to do with the abdomen, you restore that. Mm-hmm. What is a hernia, and at what point do we need to restore the abdomen?
You know, if you're gonna get me started on hernias, I'll spend all day.
Oh man!
So I'll try to minimize it as much as I can. But you know, hernias are basically a weakness in the abdominal wall. Okay, it's a point of weakness in the abdominal wall. We're all at risk for developing hernias. They're basically spots in the abdominal wall that, with increased pressure over time, they can kind of enlarge over time, allowing for the organs and the structures within the abdomen.
Is that from like obesity? Or?
Obesity plays a role, yes. Anything that increases intra-abdominal pressure. So
exercising?
Lifting weights, yes, lifting heavy weights. There are many different locations where hernias can occur. The belly button is one of them. Down in the groins are two others. Any previous surgery, a cut in the abdominal wall from before, is at risk because it never comes back to normal. If you've had surgery before and they've sutured your abdominal wall, that will never come back to 100%. That's 80%. If they cut you again in the same place, it goes down to 60%. Yeah. So that will always be at risk for developing a hernia. And so what's beautiful about hernia surgery is that it's creative. It's you got to think outside the box. Each hernia is different than the other. I just had 2 today, and it's the best part of my week is doing my hernia repairs. So when I was saying before why I chose that fellowship specifically, when I graduated, the trend was to go into MIS, and MIS is the fellowship where you kind of do the cool surgeries on all the things that you were trained to do in residency, including hernias, including bariatrics, including a lot of the other complex procedures. So hernia surgery done laparoscopically, robotically, or open, it depends on the patient and the patient characteristics, but it's a lot of fun. Yeah.
Nice. So, to my knowledge, there's 2 organs that we have that could be removed, which is the spleen and the gallbladder. And I heard that there's a relative link between bariatric surgery and gallbladders.
You can remove a lot more than just the spleen and the gallbladder. You'll be just fine.
I'm sure you can, but I'm just a dentist.
You can remove all my teeth. Gallbladder. So gallbladders, I'm sure the public would have heard about gallstones, gallbladder stones. Now the gallbladder is kind of like a little bag that sits under your liver on the right side. all it does is it squeezes whenever you eat something heavy, something with fats, something that's fried. It just squeezes in a little extra. It doesn't make the fluid that's in there. The fluid that's in there is called bile. It doesn't make it. The liver makes it. It just stores it there. So whenever you eat something, it squeezes, and that fluid goes down to your intestines and helps with absorption of the food. Now, with a sudden drop in your weight, a sudden weight loss, especially post-bariatric surgery, you are at risk for developing stones. It kind of, the fluid in there crystallizes and becomes a nidus for stone formation, and the stone just enlarges. And there are many other factors, one of them being having multiple pregnancies, recurrent pregnancies, genetics plays a role, and several others. But just because you have gallstones doesn't mean that you need surgery. And that's what I want the public to be aware of, is that, you know, some patients come to me with, oh, I just got a general checkup and my ultrasound showed that I have gallstones. Okay, so what? 10% of people have gallstones. So if you put 10 people in a room, one of them definitely has gallstones.
Interesting.
So only 1% of those people will develop symptoms. So it's only if you have symptoms from the gallstones. Usually it's pain that comes right under the rib cage, pain that goes to your right shoulder, to your back, usually after a heavy meal. That's something that you got to think about, removing the gallbladder. But yeah, a sudden drop in weight will precipitate gallstone formation in a lot of patients. Yeah, something to consider.
Interesting. All right, you're clearly very passionate about surgery at a very young age, but you do have another passion, which is teaching. You are an assistant professor at UAEU. Well, what made you join UAEU and teach?
That's a good question. You're like probing everything about my life, aren't you?
I know it all.
Look, teaching is my second love after surgery. And my wife.
Yeah,
good one, yeah. Teaching is something. It's I guess you either have it or you don't. You know, a lot of my colleagues tell me, "Why do you do that, man? It's miserable," but it's just so much fun, and just like seeing that spark in their eyes when they actually get something, and you know, one of the best things that one can do for me is call me, and one of my ex-students or ex-residents that call me and say, Dr. Shadi, I just did the procedure exactly the way you taught me, and the patient did great, and the patient's thanking me, and he really appreciates it. I mean, that brings so much joy to me. Others might say, hey, no, I just added to my competition. But no, it's great. It's just really, really enjoyable. So even in the States, I was offered the associate program director position in my old residency, and you know, it was something to consider. But I wanted to come back here in the Emirates and make an impact on surgical training and medical schools in the country. So I was the associate program director for the residency program here at Saha for at least 5 years. And I really enjoyed working with the residents and helping them towards graduating as surgical specialists. And then I moved to the university. So the university is a little different in terms of I'm spending more time with students, with medical students, usually the 5th and 6th year medical students, so senior years. And
I guess they're the only ones who can comprehend surgery.
Yeah. Then we still have to teach the more junior ones, the basic pathology stuff. But the 5th and 6th years, we deal with them both in the university and in the hospital. So I see them in the mornings in the hospital, and in the afternoons for lectures and stuff. But the cool thing about the university is it allows you to become a very well-rounded surgeon. You're not only a clinician, but you're also a researcher. You're also a teacher. So you kind of get all the 3 pillars of surgery, and you also get afforded the flexibility of having more than one personality or more than one life. Yeah. And sometimes that's nice, you know, once you're exhausted from one side of life, you just hop over to the other. Yeah, for sure. Exciting.
I think lately there have been a lot of research on education in general, being like, what is the best way to teach? You know, the concept of just sitting in a classroom is relatively outdated these days. So they're always probing and researching different ways for different personalities on how to bring the point across. Mm-hmm. So there's a very common one, which is problem-based learning, which is very popular at Harvard. What's your thoughts about that?
I thought we weren't going to talk about PBL. Made that very clear. I'm going to say no comment on PBL,
okay.
But I'm more a proponent of TBL, which is team-based learning. I kind of have my own hybrid approach to my teaching method. I enjoy getting the students to see it in real life, see the pathologies in real life, discuss them with the patients, see them in the operating room, and see them in the clinic. We have the students actually present themselves to the rest of the class, and then I put them against each other in a competition-style game show.
And like Jeopardy.
Yeah, Jeopardy. Yep, I brought Jeopardy to UAE University.
Nice.
And they love it. They love it. And honestly speaking, I mean, I've had feedbacks, forms for the past couple of years, and scores from the past couple of years, and I can tell you that the topics that I'm teaching, they've gotten the highest score in those topics, and all the feedback forms say, please, more of this style. So getting the students to be involved together as a team, and adding that competitive element to teaching really pushes students to want to learn more and want to put themselves in a position to actually study harder. Whereas if you that method of dry PowerPoint presentations where you're reading from a PowerPoint, that's just dead. I don't think it's going to last much longer. And really, faculty needs to up the ante and really find more methods to engage students.
Right. Did you think about publishing that?
Pending. It's pending publication.
All right, nobody steal that idea.
Yeah, please. I'm still waiting for an answer from the journal. We'll see.
All right. I think there's a lot of responsibilities in your hand when it comes to teaching, especially that you're teaching surgery. So, meaning that it's up to you to assess when a resident is ready. And I think that is very scary.
Yeah.
How do you figure that out? How do you know that a resident is ready to pick up the scalpel?
It's very hard. It's that's why it should never be one person's sole responsibility.
Okay. So how does it work?
So that's why we have a program director for a residency program. We have an associate program director, and you have core faculty. Core faculty are a selected group of physicians or surgeons, depending on the program, who are monitoring these residents throughout their training. They're with them in the clinics, they're with them in the operating room. We have quarterly or every 3 months meetings, and we literally discuss each and every resident in all aspects. I mean, and we evaluate them on a monthly basis, all of us, core faculty and the directors. We evaluate them on their medical knowledge, on their professionalism, their communication skills, their ability to handle stress and resources, allocating resources, all those things we're actually evaluating them on every month for their entire residency. And we sit down all together and meet to say, okay, there's an issue with this person. This person's behavior changed. This person has a personal issue. Let's work on them. Let's see how we can help. So we try to pick up issues early. We don't want to get to a situation where someone just slides through and then in the 5th year we say, oh my God, this person's not ready. So we never want to get there. Now, with regards to surgical training specifically, we kind of have a graduating or slowly increasing level of autonomy that we develop. There are different methods for different residencies, but we start off in the first couple of years. The focus needs to be on knowing how to take care of patients, knowing how to take care of them in the wards, knowing how to give them resuscitation, give them their medications, how to really manage patients in the hospital. And not only that, in the intensive care unit too, because that's really where you really can handle the most critical patients, and you learn the most in terms of applying what you learned in medical school in real life. But during those 2 years, you're also in the operating room learning basic surgical techniques. So from simple procedures like removing lumps and bumps, suturing, basic laparoscopic techniques, etc. In your 3rd year, you start to go more and more to the operating room. But then your 4th and 5th year is when you start to do the more complex procedures and we are slowly giving the residents more and more autonomy. So it starts off with, okay, let's say we're doing a gallbladder. Okay, so at first you're just holding the camera. Then you're doing the easy part of the dissection. As the years progress, you're doing the more complex procedure or the more complex part of the operation until we say, okay, this person is ready to handle this kind of operation. And so we actually sign them off on different procedures and say, okay, they're ready for this, they're ready for that. And towards the end of their residency, towards their 5th year, they're supposed to be walking their junior residents through the procedure. So they need to learn how to teach, and they need to learn how to give off responsibility to their juniors. And that's one of the elements that we look for as you graduate a surgeon.
Wow. Yeah, that's very insightful. Always had a question, or at least I get this question a lot, and I'm sure you do. Moving on to private practice, being that you're US trained, US board certified, and licensed there, what made you leave a lucrative career in the States and come to the UAE?
Well, it's a difficult question to answer because it's multifaceted. As you know, we both see the Emirates as home, and for me, it's just coming home, and there's no difficulty in that decision. Obviously, staying in the States would have probably given me a much better career opportunities. I know my career would have, been better than things are here. And sadly, there isn't as much of an awareness or an appreciation for the training that we had in comparison to the rest of the care providers here. But that's okay. I think as time goes on, society is evolving and understanding and becoming much more aware of our training background and what it took to actually achieve what we've achieved. Yeah. And I do sense that change. I mean, just 8 years ago till today, I've noticed a difference. But I'm here close to you, right? I can spend time with you over here, my family, and raising the kids here. It's been a privilege to be back, and one of the best things about it is having my kids grow around their parents, their grandparents, excuse me. And so, to me, that you can't qualify
cousins.
that. Yeah, cousins, of course.
So you have joined private practice recently in the UAE, coming back to the UAE. How are you liking private practice? Different than academia, different than a tier 1 trauma center?
Well, I don't know if I were to watch this podcast in a few years, I might laugh at myself. But to me, this is an experimental phase in my life. Because I'm usually someone who just wants to stay in a governmental hospital setting or tertiary care facility setting where I could do my big surgeries and have residents with me assisting and helping out, etc. Private practice is very different. You're out there on your own. There's no resident. There's no student. There's just you and the patient, and some assistant that will not take any responsibility for the patient after. So it is difficult, but I'd say it's also a big learning. I've learned a lot from going into private practice in terms of
managing people,
managing the hospital's expectations, understanding what hospital administrators really want from us, because you have that antagonism between physicians and administrators, especially in the big hospital setting, because we're always thinking we want to do what's best for the patient, and that's it. But then you realize there are other concerns too, and for a hospital to run and to function,
it needs to be profitable.
It needs to be profitable. And sadly, medicine has become a business, and so you need to learn the ins and outs of that to actually succeed as a physician and a surgeon these days. So navigating insurance companies, navigating billing and coding, that is what
it's a new realm for you.
It's like a whole new career for me, and I'm still struggling with it a little bit. But it's good in a way, but not as much fun as the big government hospital setting.
Yeah.
I'll tell you that.
So how is that going? Leading all these lives, like as an academician, as in a big hospital, private practice, a father, a husband, an uncle.
It does get overwhelming. But I'll tell you this: you gotta try to have your weekends to your family. I mean, I try to not answer any phone calls from work unless it's patient emergencies. I try to tell everyone knows me. Do not call me, just WhatsApp message me, because I just do not want to hear that phone ring. I'll get back to you as soon as I can, but not when I'm with family. I try my best to give my family the time that they deserve on the weekends and after hours. It's manageable, it's doable, but you just really got to be organized with regards to your time. I mean, you should look at my calendar. It's ridiculous. And sometimes I'm in 3 hospitals in the same day, but as long as it's organized and you don't miss things, it works out pretty nicely, because you kind of have that flexibility. Okay, you're sick of this place, you just hop in a car, go to the next place, and really expands your social network. You get to know providers from all over the town, and so really expands your when you're looking outside the box, you're much more creative in your solutions and ways of approaching things, as opposed to being limited to one institution where this is how we do things, this is the only way it's done. You know what I mean? So
yeah, I feel the same way.
Definite
advantages. Practicing in Al Ain and practicing in Abu Dhabi, like it's a whole different ball game, and you do learn a lot from that. And it's a whole different community completely. So yeah, I honestly think it makes you a better clinician.
Definitely.
So thank you for coming in. I really appreciate it. I appreciate your time. Where can patients find you? In private practice?
They'll never find me. I'm always jumping around. But please message me. You're more than welcome to text me. I'm sure the contact information
So what are the hospitals
around.
that you're practicing in right now?
Well, right now I'm in Sheikh Tahnoun Medical City, which is a huge 740-bed tertiary care facility.
Beautiful facility, though.
Beautiful, yeah. It's the largest garden within a hospital in the world. A really, really nice indoor garden. And I'm there in clinic on Wednesdays from 8 to 4. And then there are 2 other private hospitals that I have a short clinic in Ain Al Khalij Hospital and Burjil Hospital in Asharish. So, but feel free to message me on my Instagram account or on WhatsApp, and we can organize a consultation.
That's awesome. Thank you for coming.
Thank you so much for having me.
Thank you.
It's been really fun.
This was a lot of fun. I hope you had a good time. I was hoping that maybe the next time we have a medical doctor, you can be in my shoes. I think that'll be.
I can't fill your shoes, man. You're too good at this.
Again, thank you for coming. Everything that we talk about is completely evidence-based. We will put in all Dr. Shadi's information at the captions and on the YouTube link. We'll put in all the articles. It's not a conflict of interest, but some of the articles that we are posting is his own publications, which makes it more legitimate. So again, thank you for coming, and hope to see you next time.
Pleasure is all mine. Thank you.